Welcome to the second part of week 10 of this course, Economic Evaluation in Global Health. And as we come to the end of the course, we are looking at special topics. We wanted to use this 10th week to discuss some special topics. And in the last video, we looked at the value of vaccination. And this week, we're going to look at how economic evaluations and the methods and the presentation of these results differ in low and middle income countries. In discussing the special features of economic evaluation in low income settings, I wanted to start off by saying that there's been a rapid increase in the number of studies, the number of economic evaluation studies in low income countries in the last 10 years. And this number is likely to increase because there's greater capacity, more people can actually do the studies, and also there's increasing interest. So in some ways it's a good field to be in. And some colleagues have performed research that shows that there's an increasing number of published economic evaluation papers. And I remember one little statistic that Uganda is the country with the third highest number. Uganda is the country with the third highest number of economic evaluation studies in PubMed. So let's now look at how economic evaluations in this setting of poor countries differs from economic evaluation in the setting of high-income countries. As a way of background, disparities between the rich countries and the poor countries exist in the performance and use of economic evaluations. One can argue that the poor countries need economic evaluations more, and the reason is they have extreme budget constraints. You have per capita annual health expenditure, per capita annual health expenditure is very low, maybe between $10 to $100, just $100, $100. So it's very, very little money, and these extreme budget constraints mean that the money needs to be used more efficiently. But the disparities exist, and the reason they exist is because there are no methods that are specific to poor countries. There's capacity issues, like I said in a previous slide. There's not enough analysts, and hopefully this course would have contributed to improving this capacity, because I noticed that a lot of our colleagues in this course are from African countries. The other thing is a failure to communicate results, and then the other one is political and policy reality. Even when you produce papers, politics is much more important than policy. So even if you produce a good analysis that shows that intervention A is better than intervention B, policymakers don't have to use that evidence. And many times they actually do not. So papers sit out there without anyone using them to improve the policy. One of the issues with performance of economic evaluations in low-income countries is that the methods have evolved for rich countries. And in rich countries, the performance of incremental cost effectiveness analysis assumes that the healthcare budget is not fixed. The healthcare budget is not fixed. And there's this abstract notion of a latent overall public budget. The idea that if you find an intervention to be cost effective, you can mobilize resources from other sectors or from some place and fund a cost effective intervention. However, even when decisions are made with the idea that resources are scarce, they don't put explicit limitations on these resources. So there's no explicit limit, upper limit, for the amount of money available to pursue cost-effective interventions. Now, in poor countries, this is not the case. Budgets are very real and very limited. And as you will have seen in week 2, when we discussed the WHO paper on affordability, many countries can't even afford to pay for interventions that are cost effective based on 3 times GDP per capita. And even when an intervention is cost saving, if you remember the incremental cost effectiveness plane, where you have costs here and effectiveness here, and you have an intervention that reduces cost and in addition to that increases effectiveness in this quadrant, you might not be able to actually perform that intervention because the upfront costs may be prohibitive, may be too high, given downstream consequences. And usually there's uncertainty about the realization of these consequences. So the methods don't quite fit the low-income setting. We spoke about in week 3 this idea of discounting, and the problem in poor countries is that the discounted cost per person is not very useful to the government or to policymakers. And the reason is they have to think about the prevalent population, the number of patients who are in the current treatment pool for a budgeting cycle, maybe a year or so. And this means that you have patients coming in from previous years with their disease and patients who get sick in the current year, and all these need care during this current year, and people have to budget for that. But if you use the present value or the discounted estimate, it's not very helpful to policymakers for budgeting purposes. And the other reason is that growing populations mean that annual costs are usually going up, and they're not static. So a discounted estimate can be a distortion. And that's why it's recommended that analysts report both discounted estimates and undiscounted estimates. And I am beginning to do this in my own studies so that you can give policymakers an idea using the undiscounted estimate of the kinds of resources they need to supply healthcare in the current year to be able to better make plans for their populations. Another interesting twist in performing economic evaluations in low-income countries is the idea of supply shortages. So when I worked in a hospital in southwestern Uganda, the beginning of the month was a good time for patients because the truck came from the national medical stores with all kinds of supplies and for surgery and medicines and stuff. But then, because the demand exceeds the supply of medicines, by the middle of the month, the stores are empty, so patients don't have anything else to use. But treatment choices often vary according to availability, so doctors use what they have. And when you have this situation where you have drugs at the beginning of the month which then run out, the economically optimal strategy might be to reserve supplies for high-risk patients or for patients who need second-line treatment. So if maybe, let's say you have a second-line antibiotic like a cephalosporin, let's say you have a cephalosporin which is a second-line antibiotic, you might reserve it. Instead of giving it to a patient at the beginning of the month, you might hoard it for the patient who will come who is very sick at the end of the month. The problem is that economic evaluation models haven't been designed to take into consideration these kinds of things. This idea of the expected supply of medicines as it relates to the expected demand. And all this, remember, is to take care of the supply shortage. So given that regular economic evaluations don't do this, and people know this, some analysts know this, they are developing methods based on operations research and inventory theory to try and capture this possible impact, to try and capture the impact of supply changes and the changes in expected supply and expected demand of medicines in the context of possible supply shortages. The other difference in performing studies in low-income countries is the difficulty of health outcomes assessment. And in week 4, when we studied health outcomes, you'll have seen that the estimation of utilities is questionnaire dependent. It's dependent on questionnaires. And these questionnaires or instruments are designed for high-income countries. So if you want to use them in low-income countries, you need to translate them and adapt them culturally. And the other thing is that some countries don't have true national languages, and people speak their tribal dialects or their local languages, and essentially you have to translate instruments multiple times. So let's say you have the EQ5D, you would have to translate it into Swahili and maybe a language like Kamba and Kisii maybe. I don't know if I'm spelling Kisii correctly, but Kisii. But you would need to do multiple translations. For example, EQ5D exists in Swahili. But if you had a person who did not know Swahili, and this is common in Uganda, then you can't use the Swahili version. The other thing is literacy gaps. So I want you to imagine from week 4, you are conducting a standard gamble or a time trade-off, and you have to tell patients to put themselves in situations akin to the suspension of belief, as if one is watching a movie. It can be difficult for people who don't have adequate literacy. An example of cultural adaptation is when I was doing research many years ago in Uganda, there was a question from the MOS HIV, which is an HIV quality of life questionnaire, MOS HIV, and it had, can you walk a block? Can you walk a block? And a block in the US is, the average length of a building on a street. But we don't have blocks in low-income countries or in Uganda. And the way that I handled this was to change it from block into maybe the length of a football pitch, a soccer pitch. And this enables the survey respondent or the person filling the questionnaire to better understand the quality of life questionnaire. The other thing is policy and politics. I alluded to the fact that even when you produce a good study, you have a good cost effectiveness analysis, the policymakers might not use it because they have different ways of making decisions. And the other issue is that there are some politically popular interventions, for example, HIV interventions. HIV was a huge problem when I was a young man, and it became very politically popular. And there's a lot of funding around HIV. But it might not be the biggest problem in some countries, and you might find that if you measure DALYs, road traffic accidents or psychiatric conditions might be a bigger priority for a specific community. The other thing is that politicians usually don't think in the long term, they usually think in the short term. This is not just African or poor country politicians. It's just that the system is set up to achieve even worse outcomes if people think in the short term. In an advanced economy, there are some checks and balances that ensure continuity and ensure that the system thinks about the future and about sustainability. But in low-income countries, the fact that politicians think in the short term can have major issues. This idea of thinking for the next election cycle. And it's very difficult sometimes to change decisions in low-income countries. When people get used to doing things a certain way, coming in and saying a new intervention is better can be very, very difficult. So let's look at the needs for low and middle income countries to use and also produce and use economic evaluation evidence studies for policy making. And the main need, in my view, is capacity building. And it's actually, this is a view that I learned from my mentor, Mendel Singer. And capacity building means, training like this course, like these courses, basically, like this one we've done, and workshops. And my current mentor, Lou Garrison, and I go around countries in low and middle income countries and perform one-day workshops. Go and do one-day workshops. In fact, we have some workshops coming up in Uganda and Kenya. The other thing you need is a receptive policy audience. The idea that you can go to the minister or the director of planning of a ministry directors of planning and tell them that there's this new intervention and it's cost effective. Would you consider changing your policy? The other need is improved methods. So methods haven't been developed for doing analysis in the low-income setting. So development of methods is also another need. And finally, we have stakeholder support. There's few grants that are made to support economic evaluations in poor countries, and also, dissemination. Journal editors aren't always aware of and receptive to publishing economic evaluation reports from poor countries. So if these things change, then there's a better chance that the quality of decisions made, at least in terms of efficiency, will improve in the low and middle income countries. So this is the end of week 10 part 2, in which we looked at the differences in economic evaluations between rich and poor countries, including how there's a disparity. And I hope that I showed you the ways in which economic evaluation studies are different, as well as how there are differences in the way that the economic evaluation studies are used. And in the very, very final video of this course in week 10 part 3, we're going to look at the Consolidated Health Economic Evaluation Reporting Standards, or CHEARS, and see how if you are doing a study, the kinds of things that you need to remember when reporting your study or writing it for publication, and also if you're looking to assess a paper for quality, the kinds of things you'd be looking for to ensure that the paper meets the standards of a high quality report or a high quality study. Thank you very much, and I'll see you in the last video.